Hi everyone, welcome back to Izzy Medicine, where we make those difficult medical topics a little bit easier to understand and maybe, just maybe, even have a little bit of fun in the process. Today we're going to dive into diabetes mellitus. I might make this a two-part lecture because it's a long topic with lots of interesting concepts. And what we're going to try to do today is understand diabetes, not just memorize. We're going to try to understand what's happening in the body, why the symptoms are the way they are, and how all the puzzle pieces connect together. So let's jump in. What is diabetes? At the core, diabetes is a problem with glucose control. Glucose, as we know, is the body's main energy source, kind of like gas for a car. And in order to help our cells function, it needs to get into the cells to fuel everything from muscle movement to brain function. Insulin is the key that unlocks the doors to let the glucose into the cells. When something goes wrong with either the amount of insulin available or the body's ability to respond to it, glucose stays stuck outside the cells and it piles up in the bloodstream, and we get hyperglycemia or high blood sugar. We have two types of diabetes, type 1 diabetes and type 2 diabetes. Type 1 diabetes is what we call an autoimmune disease. This is where the body's own immune system mistakenly attacks and destroys the beta cells in the pancreas. These are the very cells that produce insulin. Usually type 1 diabetes happens in children, teens, and adults under 30, although it can happen at any age, but that's most common. Why does type 1 diabetes happen? There are some predisposing factors, but who knows why. But the predisposing factors are genetic predispositions, so things like HLA-DR3 and HLA-DR4 mutations, and sometimes an environmental trigger like a virus or some other immune trigger. This kicks the system into overdrive. This overdrive causes the body to attack the pancreas instead of fighting off whatever immune trigger there was. And specifically, it attacks the insulin-producing beta cells. The body even creates antibodies like anti-GAD antibodies to help destroy beta cells. So it's just an all-out attack on the beta cells in the pancreas. What happens is, the result is that we have no insulin, hence no key to unlock the glucose doors, and the glucose piles up in the blood, but the cells are starving. They're starving for energy because, as we know, we need the glucose inside our cells to power us up. How does the patient present? So in type 1 diabetes, we have the 3 Ps: polydipsia, polyuria, polyphagia. So polydipsia is intense thirst. The reason this happens is because glucose in the bloodstream increases the blood's osmolarity because it's a solute, and we have osmoreceptors in our body. And the osmoreceptors sense that the blood is thick and syrupy, almost, from all the sugar. And it sends a signal to our brain to let us know that we want to dilute this, to make it not thick and syrupy, to make it back into normal. And that triggers the patient's thirst mechanism. And it's just intense thirst, trying to hydrate as much as possible. Then we have polyuria. And the reason that the patient pees a lot, not just frequently, but a lot of urine in terms of output, is again because it's a solute and because we're trying to get rid of the glucose. The body tries to pee out the glucose, but because it's a solute, it pulls water with it into the urinary system, and the patient pees a large amount of water together with the glucose. So this constant peeing leads to dehydration, and the dehydration leads to the blood thickening, which leads to the patient being thirsty. So we're in a loop of thirst and peeing, thirst and peeing. Additionally, because there's tons of glucose in the bloodstream, but they're not able to get into the cells and the cells are starving, we get polyphagia, which is excessive hunger. The patient is unable to get energy into the cells and is starving, essentially. If you've ever seen pictures of diabetic children, type 1 diabetic children, before the invention of insulin, you would see emaciated children because they're just not getting any energy in, and they're also losing weight because the body starts breaking down fat and muscle for fuel to try to get some source of energy, and the patient starts wasting away. Type 2 diabetes is a little different. This is where there's resistance to insulin. So the pancreas is still producing insulin, and the problem here is that the cells stop listening. They become resistant to the message. Why does this happen? The the main cause of insulin resistance is actually metabolic syndrome. And metabolic syndrome is made up of obesity, usually central abdominal obesity, high triglycerides, low HDL, which is low good cholesterol, high blood pressure, and elevated fasting glucose. What happens from metabolic syndrome is that inflammatory molecules that are released from the fat tissue around the abdomen or elsewhere, they mess up insulin receptors on the cell surface, so the message is not transmitted. The insulin is there knocking, but the doors don't open properly. They don't respond to the insulin. So this is why weight gain or excessive weight is such a big factor in insulin resistance and type 2 diabetes, because of these adipokines that mess up the message. What happens here? The blood sugar stays high. The pancreas, in turn, because it's still producing insulin, it's trying harder and harder and harder to pump out more insulin. But eventually, as the beta cells get exhausted just pushing this insulin out, they become fibrotic and they start dying off. So even in type 2 diabetes, eventually the number of beta cells starts diminishing and we get resistance and diminished insulin production. Type 2 diabetes patients are a little bit different. They're often older, over 40. And unfortunately, with rising obesity, we have type 2 diabetes younger and younger now, but usually it's not as young as type 1. And unlike type 1 diabetes, where we have the polydipsia, polyphagia, polyuria, the symptoms here might be slower and more subtle at first, like tiredness, slow healing wounds, blurred vision. We'll discuss why shortly. And later on, as type 2 diabetes progresses, as the sugar is consistently elevated, we also might develop that polydipsia, polyuria, polyphagia that's in type 1. Okay, so now that we know why patients with diabetes feel thirsty, hungry, and why they're running to the bathroom, we need to figure out what happens when this kind of situation spins out of control. And this is where we get into our diabetic crises. So we have two types, diabetic ketoacidosis, DKA, or HHS. Let's start with DKA. DKA is diabetic ketoacidosis, and usually it's in patients with type 1 diabetes. And why it happens is because there's zero insulin. And as we remember, insulin's job is to help glucose get into the cells. And without insulin, the glucose stays outside of the blood and the cells are starving for fuel. This is where the body panics and it says, I need energy somehow. Give me energy right now, please. And it starts breaking down fat really fast to make backup fuel for our body. And when the fat is broken down, the body makes something called ketones. And ketones aren't all bad. They can be used for energy, but ketones are acids. That's the catch. And when there are too many ketones in the blood becomes too acidic. And that's where we get acidosis and ketoacidosis. What happens here? So imagine the blood is too acidic. We have a sugar of over 250, which is what usually happens in DKA. And now the body is in high sugar and also in acidosis. So we get symptoms such as rapid deep breathing called Kussmaul breathing. This is where the body through the lungs tries to blow off as much carbon dioxide to make the blood less acidic. We also have fruity smelling breath. And this is when, again, we're trying to expel the ketones, and we expel a ketone called acetone, a type of ketone, and it evaporates and we get that fruity breath. There's nausea, vomiting, and abdominal pain because the acid messes with the stomach and the gut. We have the extreme thirst and peeing a lot because the sugar is so high and water is pulled into the urine and we're getting dehydrated. And we also sometimes get into confusion or even coma because not only is the blood not getting enough nutrients such as sugar, it's also not getting enough fluids and everything is sluggish because the patient is dehydrated so severely. So that's type 1 diabetes. And in something a little bit different, we have HHS, which is hyperosmolar hyperglycemic state. And that's usually a crisis in people with type 2 diabetes. And the key difference here is that the patient's still able to make some insulin, but it prevents the body from making ketones. It prevents that full breakdown of fat, and there's no problem with acid, like in DKA. But the blood sugar goes crazy high. So in hyperosmolar hyperglycemic state, it can be over 600, and sometimes more. When sugar levels get that high, it basically sucks a ton of water out of the body in the process that we already mentioned. And the patient's peeing gallons, severely dehydrated, and the blood is syrupy. And the blood doesn't flow well, and the brain doesn't like that. So again, we have extreme thirst, frequent urination, dry mouth, dry skin, sunken eyes, and again, confusion and even coma, because we're not getting enough blood supply with how syrupy this blood is. But to reiterate, there is no fruity breath because there are no ketones to get rid of, and there's no acidosis. So now that we know what happens when the blood sugar goes dangerously high, what happens on a day-to-day basis when the blood sugar isn't spiking in crisis, but stays a little too high day after day, year after year? This is what real diabetes is in most cases. This is the patients that we see the most in the primary care setting, at least. And this is where the long-term damage is seen. It's sneaky because patients don't feel it happening until it's far along. And what happens here is that high blood sugar damages blood vessels. It damages big blood vessels, which is macrovascular damage, the ones that supply the heart, the brain, the legs, and it damages the tiny blood vessels, which is microvascular complications, and those are the ones that feed the eyes, the kidneys, and the nerves. So let's start with the big vessels first and discuss what happens there. When sugar levels are high for a long time, glucose starts to stick to proteins and fats inside the blood vessel walls. It's a process called non-enzymatic glycation, and when that happens, it's almost like the inside of blood vessels gets sugar-coated, not in a good way, not in a yummy way, but in a way that makes the vessels stiff, thick, and fragile. And they build up inflammation because of all this sticky buildup, and it invites cholesterol to pile up. And over time, you get plaques forming inside the arteries, and it makes them narrower and narrower, and that's how we get atherosclerosis. If the arteries that supply the heart, like the coronary arteries, are affected, the patient can develop angina, which is chest pain with exertion. Or worse, they can suffer a heart attack, especially if a plaque ruptures and blocks the vessel. If the arteries going to the brain are affected, like the carotids or cerebral arteries, they can have mini strokes, which are TIAs, or even a full-blown stroke. And if the arteries going to the legs get clogged, patients might start complaining of pain when they walk, which is called claudication, or they might notice that wounds on their feet are not healing because there's not enough blood supply getting there. And in really bad cases, if there is very diminished blood supply, they can lose a toe or part of their leg because the tissue dies off without the blood supply. And that's a scary thing, and a lot of damage is happening quietly in the background without much warning, unfortunately. Now let's zoom in on the microvascular complications, and this is where the smallest blood vessels are affected. In diabetes, this show up most commonly, like I said, in the eyes, the kidneys, and the nerves. And even though the vessels are tiny, the damage is massive if we don't catch it. Let's start with the eyes. So we have diabetic retinopathy. What happens there is the high blood sugar damages the delicate capillaries that supply the retina. This is the part that senses light and sends visual signals to the brain. So what happens at first is these vessels start to weaken. They form microaneurysms, the little bulges in the vessel walls. These leak, and they can leak fluid and fat into the retina. The leakage leaves behind yellowish spots called hard exudates, and these are deposits of lipids in the retina, and we can actually see these on exam. This is one of the signs on exam of diabetes. Over time, if part of the retina isn't getting enough oxygen, the eye, of course, tries to create alternate routes of oxygenation. It creates new vessels, but the vessels are tiny and they're fragile and they're not well formed because they're building rapidly and they break easily. And then those break and bleed into the eye and they cause a vitreous hemorrhage. And in bad cases, they can even pull on the retina and cause retinal detachment. And through this process of leaky capillaries and bleeding, we can get
if we don't catch it and we don't tell our patient to do a yearly eye exam and check up on them, we can get scarring and we can even get to blindness. So we want to catch this before vision is lost, and we recommend for our diabetic patients to have a dilated eye exam every year. Let's talk about our kidneys. Diabetic nephropathy is essentially the same process, but in the tiny filtering units in the kidneys, the glomeruli. And that's the glomeruli take a hit here. Glucose stays high. It damages the glomeruli by thickening their walls, increases pressure inside the vessels, and this weakens the filter. And it lets albumin, which is a protein that normally stays in the blood, it starts slipping through the urine, into the urine. And then when we see albumin in the urine, we can call it albuminuria. Early on, it's usually a small amount, sometimes called microalbuminuria, which is kind of a misnomer at this point. And then we can catch it by running a urine albumin to creatinine ratio. If the damage keeps going, more protein is lost. Eventually, the patient might spill large amounts, more than 3.5 grams a day, and we call this nephrotic range proteinuria. And at that point, once the damage is progressing, we can see a rise in creatinine, glomerular filtration rate, GFR dropping, and over time, this can lead to chronic kidney disease, end-stage kidney failure, and might lead to dialysis. The big takeaway here is that damage starts at the level of the capillaries. It shows up early as protein in the urine, and so we check it routinely, and we can often slow it down or even reverse it if we reverse diabetes altogether, and we don't want to get to kidney failure. Finally, we have our nerves. Diabetic neuropathy happens because, number one, the small vessels that feed the nerves get damaged, but also because the metabolic stress inside the nerves themselves. What happens is glucose enters the nerve cells and gets converted into sorbitol. And because there's such a high amount of glucose, there's a high amount of sorbitol, and that draws water and leads to swelling and damage to the nerves. So the nerves are being injured from the inside out and from the outside in. So they're not getting enough blood supply and they're getting swollen. From this diabetic neuropathy, the patient might have numbness, tingling, burn-in pain, and they might have what we call a stock glove type of pattern, which is basically from the toes up, kind of like a sock. And over time, patients can lose full sensation, and this is where it gets dangerous for our patients. They can step on something sharp or develop a foot ulcer and not even realize that it's there. And you combine this with poor circulation from the peripheral arterial disease, from the macro complications, and the wounds don't heal well. And this is where we have chronic foot ulcers, infections, and this can lead to amputations. So this is where foot checks come in. With every visit with a diabetic, we educate, do you check your feet on a regular basis? And this is for them to look, to make sure that they don't have anything there that they didn't feel. Unfortunately, neuropathy is not just a sensory situation. It can also affect autonomic issues, the autonomic nervous system, and this is the system that controls automatic body functions like digestion and blood pressure. A lot of diabetic patients have gastroparesis. So gastroparesis happens when the nerves that help the stomach contract and empty are damaged. The stomach doesn't empty properly. Everything just moves slower. Food just sits there longer than it should, and it leads to nausea and bloating and that feeling of just being very, very full after a few bites, and it's very, very uncomfortable. And it's from the damage of the nerves that get the gut moving and in rhythm. There's also orthostatic hypotension, and this is where a patient feels dizzy when they stand up. Normally what happens is the blood vessels tighten a bit to keep blood going into the brain when the patient stands up. But if the autonomic nerves are damaged, that reflex doesn't work, so the vessels stay too relaxed, they don't constrict. Blood pools in the legs and not enough gets to the brain, and the patient may feel faint. So diabetic neuropathy is a double whammy. It can affect the gut, the heart, the blood vessels. Okay guys, this is a wrap on part 1 of diabetes mellitus. I hope you learned. I hope you had fun. I hope that it was a great day. I'm hoping you're going to join me in part 2 of diabetes mellitus, where we're going to talk diagnosis and treatment. If you enjoyed, please subscribe, like, press the notification bell, and I'll see you in the next one. Thank you for listening, and stay curious. Bye.